You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she is also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hi, everyone. I'm Tania Jain, and we're back. Welcome to the podcast Myelofibrosis for Medscape in Discussion. And the guest we have in-house today is Dr. Jeanne Palmer, and the topic for today is transplantation in myelofibrosis. I have a very special guest today, Dr. Jeanne Palmer, who is a hematologist at the Mayo Clinic and has clinical and translational interest in myeloproliferative neoplasms as well as bone marrow transplantation. And the quick point to make here is that Dr. Palmer has been my mentor since fellowship, and pretty much everything that I know about myelofibrosis and transplant is because of Dr. Palmer. So a huge welcome to you, Dr. Palmer, on this episode.
Well, thank you so much for having me. Always a pleasure, and you certainly have been one of my most successful mentees.
You're very generous to say that. So we'll start with our discussion in transplant and myelofibrosis, which I know is a very special topic for both of us. And I'll start with the phrase that we put together at some point in one of our writings, which was phrased as saying timing is everything. For transplant and myelofibrosis, that's certainly the truth. So tell me a little bit about how do you navigate timing of transplant and myelofibrosis, or how do you think about when to take someone to transplant and myelofibrosis?
That's a great question, and I think a continuously moving target. You know, when we think of sort of the standard guideline type approach, you say, well, we want to take somebody who's intermediate 2 or high risks based on DIPSS score or on MIP70 and bring somebody to transplant then. I think it can be a little bit more nuanced than that. There's a couple pieces to remember when we think about survival curves. Number one, the DIPS and the DIPS Plus, both were published prior to the commercial availability of ruxolitinib. I always take pause in trying to estimate survival based on those. With the MIP70, it's an excellent score to try to incorporate both the clinical aspects of the patient as well as the molecular aspects. I also use hesitation with that because it's very heavily weighted on some of the molecular and cytogenetic aspects of the disease. So you can be high risk and actually have very few other clinical manifestations in terms of anemia or high white blood cell count, things like that. I use caution if somebody is low risk based on like the DIPSS or DIPS Plus, but high risk on just based on the MIPSS 70, primarily because that would be transplanting somebody purely based on mutations, which I hesitate to do.
That makes a lot of sense. And as Christina Gowen published our, the study with CIBMTR using DIPS, also kind of alluded to the same fact that intermediate 1 and above, intermediate 2 and above for sure, is someone to be considered. I will say, and tell me what you think about it, I feel like I personally have, as much as I use the risk scores in making decisions, I feel like I've moved away from using the score per se and more using instead the individual components of the score. So like cytopenias are, kind of telling that something needs to be done, or high-risk mutations. So my 4 things that I look at is mutations, cytogenetics, as well as somatic mutations, blast percentage, especially if it's like higher than 10% or so, cytopenias, and spleen response, which is something that I've begun to think about more and more, especially now that we have more JAK inhibitors and the RR6 to speak to the fact that people who are not responding to Jakafi right away or any upfront JAK inhibitor, perhaps, they're probably not positioned well in terms of their disease control. Does that sound reasonable?
Absolutely. And to kind of clarify how I approach it is what I do is I take into account the things that you talked about, the cytopenias, the white blood cell count. A lot of it's also trajectory over time. I always tell patients to be very cautious when they look at their white blood cell count or their labs, because you can have big blips. I have people who their blast count shoots up, it stays up for one blood test and comes right back down. That can be related to things like infection. I like to look at the trend over time. Now, where those molecular markers I feel are extremely helpful is if I have a patient whose blood counts start to change and they sort of get into that gray zone of transplant, because I feel like it's a big window of time in which we have. It's trying to figure out where to go. I bring people a lot earlier if they have the high risk mutation. So if I start to see developing of anemia or an increase in the white blood cell count, I'll probably jump on it a little bit faster. But I agree. I think it's sort of putting all the pieces together and then also taking into account the patient preference. I've certainly delayed transplants to help make sure somebody can go to a wedding or see a graduation or make sure that they're able to experience something meaningful in their life, especially if they're still in that zone where they're still kind of early on and maybe have some blasts, but 2% blasts or something, their white count's not rapidly changing.
Absolutely.
You have some time to really take pause and say what's really important to you, because that is a big piece of it. And when the transplant doesn't go well, I'm always glad to be able to say, hey, you got to go to that wedding. Or I had a patient who passed away from transplant, and I delayed it for maybe 2 months to go to a wedding. And after he died, his family wrote me a really nice card. And one of the things they actually mentioned was, thank you for letting us do that. But that being said, a lot of times it's people's preference. I think one of the challenges, as you alluded to, is now we have more JAK inhibitors. Looking at the response to JAK inhibitors is extremely important and something that I will use as sort of one of my criteria for trying for transplant. I think one of the hardest parts I'm experiencing, and I'd be interested to see what you think, is you'll have a patient who's on a JAK inhibitor, became more anemic. This is a person historically, I would say it's time to go to transplant. And then they say, well, okay, momelotinib. Perfect example. Patient in this experience, I gave her momelotinib. She's like, I really want to go on this trip to Japan. It's so important that I go to Japan with my sisters. This is a big trip we've been planning. I said, okay, all right, let's go ahead and let you do that. We'll follow your blood work, make sure nothing looks like it's getting out of control in the interim. She went to Japan. By the time she came back, her hemoglobin went from being transfusion dependent to being 11.5. And she feels great. And so you say, well, what do you do now? Because obviously if momelotinib quits working, we're in a bit of a bind. She clearly has the biology of the disease that has anemia, which we know creates a higher risk. Do we mitigate that risk by giving somebody something like momelotinib, which will increase the hemoglobin? Or do we still have that same underlying biology of the disease trucking along?
Yeah.
In her case, I actually did still recommend transplant, but she really did not want to do it. And so we decided to hold off and to continue to follow her closely. But I think that's one of the challenges is that, now we do have the RR6. We do have this response to ruxolitinib, which I think is wonderful because there are patients who may be able to buy some time before they have to get a transplant.
I'm going to pick on two of the things that you mentioned. I think the trajectory piece I totally agree with. And so many times I've had this in clinic where I'm seeing a new patient with a new diagnosis. Somewhere feels like in the gray zone. And you say that, yeah, let's see where this is going. Let's recheck your blood counts. Is the 11 of hemoglobin staying at 11 or is it going to trickle down to 9s and the 8s? And see how the clinical trajectory of this, along with blood counts, is going over the next 6 months or so. So totally agree. And the second point you bring up is very critical as to how the role of transplant is going to evolve and the timing of transplant is going to evolve with the emergence of JAK inhibitors and hopefully in the near future, non-JAK inhibitor novel agents. Do we wait when we're seeing a response to the second JAK inhibitor, in this case, for example, or do we take that as a cue that, the options are limited and transplant is the way to go? I think for the anemia piece, I will say that I feel slightly differently, perhaps, that the anemia that comes with start of the disease, I feel is certainly the more aggressive type than the one that happens as a result of Jakafi. I'll be very curious to see how momelotinib and even, data from luspatercept or even perhaps BET inhibitors in the future settles in that regard.
And I agree. And I think the anemia from Jakafi doesn't bother me nearly as much. I agree with you on that front entirely. And there's some data that shows that, but also, we kind of expect that based on the JAK inhibition. I had a patient recently who started with anemia, and she was put on a big spleen and started on JAK inhibitor. And within 2 months, her spleen normalized and her hemoglobin actually never dropped and went up a little bit. And she only has a JAK2 mutation and no other elevated white count or blasts or something. So we actually decided to hold tight for a little bit because of that excellent response to a JAK inhibitor. The hard part is people who are on a JAK inhibitor doing well, they start to decline. Those are the patients, like I always would say, okay, this is the time, let's go. Those patients now can be on momelotinib, pacritinib, these ones that have the ACVR1 inhibition. You're right, BET inhibitors, luspatercept. And I'm still kind of holding out. I think we do have survival data that if you become transfusion independent and have anemia responses to momelotinib, your survival is better. I don't know that I completely translate that to saying, okay, I've changed the disease enough that I'm not worried about that impact of anemia on the risk of progression to becomes more difficult to treat.
That's a question that I struggle with as well, because I don't think I know the answer to whether anemia improving from momelotinib is good enough or not. I think if they have high-risk mutations, I'm still inclined to take them to transplant. I think if everything else is looking kind of on the stable side, then I may defer. Obviously, a lot of other things come into consideration as well. I want to segue a little bit into the transplant platform. I know this is something that all of us do slightly differently based on institutional preferences, our own experiences, and so forth. Would you be able to share a little bit about what is your favored platform for transplant, including like GVH prophylaxis, donor, conditioning, graft source, blood versus marrow?
That has been kind of a moving target a little bit for me. So historically, I would primarily go with Flumel. If I had a younger patient who had myelofibrosis, I'll often use full dose, myeloablative busulfan along with fludarabine. Recently, I have changed though from Flumel over to Little Bu-Flu based on some of the data that was presented a couple of years ago at ASH that suggested that people did better with that. So I have changed that. I'm kind of holding tight to see how things look with that and whether I find that the transplants are successful with it, but people definitely seem to tolerate it better, which is kind of what we would expect. Now, in terms of graft versus host disease prophylaxis, I actually started using post-transplant Cy, and I know that the study that made post-transplant Cy really on the map entirely was one that excluded patients with myelofibrosis. But that being said, I think that mitigation of risk of GVHD is huge. So I've actually been using post-transplant cyclophosphamide in patients, unless there's a reason not to. That's irrespective of ablative or not reduced intensity conditioning, fully understanding that most of the data that was really excellent was with reduced intensity conditioning. So I have started using that post-transplant cyclophosphamide. And so far, I have not had any significant negative complications from it, but I'm still kind of watching how it's going with that. Historically, I used to use tacrolimus, methotrexate, and a dose of ATG, kind of going along the lines of what they do in Germany. And I felt like that was also a pretty effective approach. You want to kind of stick with what you know, but on the other hand, you want to grow with the data that becomes available. So I have had some changes. So right now I would say I use a busulfan-based conditioning, either reduced intensity or fully ablative, depending on the age of the patient. And then post-transplant cyclophosphamide, tacrolimus, mycophenolate as my GVHD prophylaxis.
I see. Interesting. And then with the Bu-Flu, is that like a non-myeloablative dose, or is that more like a reduced intensity 3-day dose?
I've been using the 2 days, but I think I might try to start using the 10 doses, especially on a patient who has higher risk of their disease, but yet is not at the point where I'd feel comfortable using full dose busulfan.
Are you seeing sort of a difference in your graft failure rates? Because I know you used to use Flumel quite a bit. So are you seeing a difference? But Flumel is kind of on the higher side of the intensity. Yeah. And now you've shifted your intensity a little. Have you seen a difference in graft failure?
Not really. I just started doing that, I would say probably in the last 6 months or so. So it may not have manifested as of yet just because I don't have long enough follow-up for the patients. I'll have to kind of wait and see about that. And then, the post-transplant side, also you worry about that graft failure as that's one thing that we can be seeing with use of post-transplant Cy. I will say I have had some relapses and graft loss, but I don't think it's actually been related to post-transplant Cy or the busulfan and fludarabine, because these have been in patients, who have gotten both regimens. So I don't know that I'm going to thoroughly put that on the shoulders of those changes at this point.
So what our strategy here now is flu-side TBI 400, so more like a reduced intensity, with peripheral blood graft for everyone and with PT-Cy. And the way that evolved is when we started, I wasn't here at that time, but when they started doing PT-Cy, I think there were a couple of graft failures. And then we made a few modifications to up the TBI to 400 from 200, make it peripheral blood for all MPNs. We do a couple of rounds of hypomethylating agents prior to transplant to quote unquote soften the marrow, or basically to immunosuppress to allow for the graft to settle in. And with that, in the last 4 years, we've seen 0 graft failures in about 30 or 40 patients that we've done. Now, I will quote a bit on purpose, but I will quote our recent analysis that just got published in Blood Advances, which looked at the 4 donor types, so matched sibling versus haplo-PT-Cy versus MUD, regardless of PT-Cy, and versus mismatched MUD. And the reason I brought graft failure up was that in this particular study, about 1,000 patients, one of the things that the overall survival was similar between the 4 options beyond 3 months. In the first 3 months, there was an advantage with matched sibling, but the other 3 were about the same. But the one thing that was striking was graft failure, in that haplo-PT-Cy had a much higher graft failure rate. And that's so different from our experience here, part of it is, which is published also. That's kind of where I struggle a little bit as to how can we improve that, because adding haplo to the donor pool will hopefully broaden access to transplant for these patients where a matched donor may not always be available. But I also want to try to endeavor trying to decrease that horror or that bias that we have with graft failure.
I think that paper is great that it's out, because it's certainly been long in the coming to figure out how do we navigate these different donor types with myelofibrosis. I actually have been leaning towards mismatched unrelateds versus haplos. But honestly, even knowing that, I'll still use a haploidentical donor to transplant somebody if they're high enough risk. And I think that the key about any of these donor types, and especially if there's a mismatch, is really making sure the patient understands that the count recovery is going to be slow. I have a gentleman who's a year out from a haplo transplant, and he still requires Neupogen every now and again, and his counts are still not pristine, but he's still 100% donor and in a pretty good spot. So I think that the key point is making sure to set expectations right for not just the patient, but also your colleagues who are going to be taking care of this patient in the hospital, so that we don't view them in that same lens of, oh my goodness, your counts aren't coming up. This is doomsday. Because I think often they do actually eventually recover their counts. Just it takes a little bit longer.
Absolutely. And you're taking us to our next discussion here, which was going to be about, we know poor graft function is a challenge and is a unique challenge in myelofibrosis transplants. So how do you usually prepare your patients about sort of the risks versus benefits, considering for the poor graft function that may happen? What is your usual discussion with the patient as you're planning them for transplant, and what all does it include?
The way I kind of look at it is a little bit pragmatic, in that when somebody needs a transplant because their disease is so bad that they're going to otherwise be at very high risk of things like AML, early deaths, et cetera, because of it, I feel like at that point, that sort of becomes the predominant issue. And so when we talk about the risks of it, I always mention, if you talk to your neighbor and your neighbor says my counts are normalizing and yours aren't, that's a normal thing. I think it's more preparing people, because when it comes down to the decision of transplant, that is really sort of a decision you make, and then you take into account things like low blood counts or graft versus host disease, things like that. And you say, this is what to expect from these risks. I will say generally people make the decision. My experience is they make the decision about transplant. This is sort of irrespective of some of these risks. I think they, obviously by the time they've gotten to that point, they've heard us talk about things like the risk of chronic disease, the risk of graft versus host disease, the risk of dying from transplant, and they've already come to terms with that. So when you talk about things like, okay, your counts may not completely recover or this, that falls under that umbrella. And I think it's mostly setting up expectations rather than becoming like a deal breaker. But that being said, that's what I make sure that they're aware of is that risk. And patients usually are okay with that. We were talking about what are the important factors. And when we think about that risk benefit analysis, that kind of brings us to the next point is how do people even look at that? I mean, irregardless of some of the smaller aspects of it, like the big picture. And that's always a tricky one because obviously that weighs into timing, because one of the reasons that we don't just transplant people when they come is because we're saying, look, this could cause you to die. This could cause you to have chronic illness. Your disease can still come back. We could be taking away time from you. And so when we think about the risks, so what are the other things? It's not just about dying or living. It's also about quality of life. Granted, one of the pieces of quality of life is the need to go in for transfusions all the time. But we actually looked at quality of life after transplant in some patients. It was a study done here and in Germany. And we found that, interestingly, when you looked at that sort of that patient global impression of change, which I think is a very helpful marker, sort of the was it worth it question. Over half the patients who are survivors at 1 year felt that it was worth it. That being said, you'll definitely see ups and downs in terms of their symptom score at various time points during the transplant. But I think that the key takeaway message from that, and the one that I like to share with patients, is over half the patients felt that it was worth it.
Yeah. And you've looked into this quite in depth, both from a non-transplant and a transplant perspective, including sort of reasons why patients may not prefer to go through a transplant for a chronic malignancy like myelofibrosis. What are the pearls sort of leave from here with regards to that? And what are the barriers that you think mostly confront us?
Patient advocacy websites are wonderful. They provide so much support for patients, give them a community of other patients who have that same diagnosis, which is so rare. I mean, they go up to somebody in their life and say, I have myelofibrosis. They're going to be like, what the heck is that? I don't even know what that disease is. So having that community is important. But on the opposite side of that coin, everyone goes through their own pathway, their own experience. Their perception of their experience is often colored by previous experiences and the way that they look at the world, which can be very different. And so you'll often hear so many different stories. So patients, I found, often come in with a preconceived notion. Sometimes they're like, I want this transplant. And I said, okay, I don't think now is the right time, or on the opposite side, they're like, I don't want the transplant. And they have they're saying, oh, this person did so bad and they were so miserable. So trying to overcome some of those expectations, positive or negative, can be very, very challenging. I think that it's less predominant. I think there's more and more success stories that are out there of transplants. So I think I don't hear that as much as I did probably 7 or 8 years ago. But the preconceived notions that people come in with of whether they should get a transplant or not, I think can be a big challenge. What the perception their referring physician has. I mean, referring physicians often are very biased. If you think about historically, transplants for myelofibrosis, when we waited too long, were incredibly tough and patients didn't do well. So their physician who's known them and diagnosed them has said, oh yeah, these transplants, these aren't good things. You don't want to do that. Then they often will be biased by that perception of somebody that they know and that they trust. There's a lot of biases that they come in with that are difficult to manage.
Yeah, I agree. I think partnership with myelofibrosis experts, with referring oncologists, I think is critical. I think you and I have a slightly different practice in a way that we see our myelofibrosis patients before transplant and even after, so we don't specifically see them for transplant. But I think in practices where there is a different myelofibrosis physician and a different transplant physician, I think that early referral and trying to overcome those barriers to access for transplant for the sake of some preconceived notion and memory bias and things like that, I think is very important to overcome. So we're running out of time here, and obviously I enjoyed every bit of the discussion. What are your final words for people who are listening to this and thinking about transplant for myelofibrosis for their patients?
Well, I think that in anybody who is less than 75 and has myelofibrosis, having that discussion, having them meet with a transplanter, and I always encourage people to meet with a transplanter who understands myelofibrosis. There's a number of us across the country who do really take interest in making sure to understand not just bone marrow transplant, but transplant for myelofibrosis, which I think is somewhat unique. I think that that's a really critical piece of it. Even if they don't get the transplant with that provider who specializes in it, at least to get their input and thought process behind it is extremely important. So I would say just make sure that patients get the information that they need from somebody who understands it so that the patient can make an educated decision about whether that's something that they want to do or not. And really making sure to include the patient in that decision-making process. I think our job is to provide the appropriate education so people can make a decision that's going to best fit in with their values and their life and their desires. So I think those are, I think, the key pieces. In terms of timing and everything else, that's going to be a moving target. And that is something that I don't think we can give pearls on as much as it's trying to say, understanding what things impact these decisions.
I don't think anyone could have said this better as you did, Dr. Palmer. I think this is perfect summary of our discussion today. With that, I'm going to end, and we will see our audience with our next episode. Thank you again, Dr. Palmer, for taking the time and educating us and discussing with us the various nuances of transplant and sharing your experience. Thank you, everyone.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.